dermoscopy. And to start off the day, we recognize and respect the Kanien'kehá:ka as the traditional custodians of the lands and waters on which we meet today. This land has long served as a site of meeting and exchange among many First Nations, including the Kanien'kehá:ka of the Haudenosaunee, Confederacy, and Huron-Wendat, Abenaki, and Anishinaabe. I acknowledge that we are all settlers, new and generational, who benefit from this land due to our privilege. We don't have much to disclose. However, there could be potential for conflict in that we will be talking about different dermatoscopes and, of course, their manufacturers, and potentially talking about some discounts that are perennial discounts that some of these companies offer for students. However, we are not benefiting from those discounts, and neither is this presentation sponsored in any way. So the objectives for today's talk are to discover what the dermatoscope is, how it works and its types, learn an approach to dermoscopy of pigmented and non-pigmented lesions, but we'll focus today on pigmented lesions, and also to explore how to incorporate dermoscopy in primary practice. So I guess a lot of us, and I get asked this question quite a lot, why should I do dermoscopy? You can do it because you're interested in derm, or other people can do it, but why me? It is expensive to purchase, there is no remuneration for it, and it takes a long time to learn a new skill. So I'm hoping that some of those questions can be answered as we walk through. So starting off, what is a dermatoscope? Dermatoscopes are handheld devices used for evaluation of skin lesions, and the practice of using them is called dermoscopy. They have a trans-illuminating light and magnifying optics, and they allow the visualization of subsurface skin structures located within the epidermis, the dermoepidermal junction, and the papillary dermis, which are otherwise not visible to the naked eye. The cost of dermatoscopes can be anywhere from $350 to over $1,000. As well, if you're attaching other gadgets to it, like cameras, etc., storage devices, then the price will definitely go up. They come in multiple shapes and sizes and weights, so there is something for everybody based on your ergonomics. My first and the dermatoscope that I use currently is the Hein IC1, and I've mounted it on an iPod, as you can see. This is the exact picture. And the image on the right-hand side is actually the first picture I took from the dermatoscope after a picture of my own mole on my hand, and this actually turned out to be a malignant melanoma in situ. So right off the bat, the dermatoscope was a very useful device in my practice. The Hein dermatoscopes actually come with an app which allow you to track lesions over time. So for example, here's a patient of mine, and with their consent, I can show you how over time I've been mapping some moles, which at the time don't look very worrisome, but definitely I can watch them over time and remove them if needed. So how do you choose a dermatoscope? I mean, obviously it will depend whether it's an entry level, if it's your first dermatoscope, your budget, the design of it, and the needs, right? So do you want to use an app for mole mapping like the Hein? That was one of the reasons why I chose that one. And if there's one that's more compatible with your EMR, you'd go for that. During the whole presentation today, we'll be giving you little tips. And the first tip for today is the Primary Care Dermatology Society of Canada, which came into being about 7-8 years ago. And some family physicians with interest in dermatology created this to exchange information and knowledge. They hold an annual conference and multiple other workshops as well during the fall, once in Toronto and the next in Vancouver. And they have multiple dermatoscope vendors, as well as at discounted rates, as well as multiple sessions on dermoscopy. So if you want to further your knowledge, that's a great place to be. How do dermatoscopes actually work? So during a naked eye exam, light is reflected off the skin, hence we can't see the structures underneath the top layer. However, dermatoscopes eliminate the light via light-emitting diodes, and this light can be either polarized or non-polarized, and I'll go into some details of that. So non-polarized light requires a liquid interface. Normally, people who use dermatoscopes a lot would use an alcohol swab to make the surface a little wet, and so when your dermatoscope touches the skin, there's an interface or a medium between them. Polarized light, on the other hand, does not require any medium, so you can just put it against the skin or even keep it away from it. And sometimes you have to keep it away because you don't want to press the lesion, as it can make the blood vessels go away. Most dermatoscopes nowadays are hybrid, so you can toggle between polarized and non-polarized. And what does that actually mean? So when light is emitted from any source, as you know, Physics 101, it will travel in multiple directions, so that's non-polarized light. However, if we focus it in one direction, it becomes polarized. And what does that mean? This is what it means. In non-polarized light, obviously some of the rays are reflected off of the surface, so you're seeing the surface, but some of it goes through and you can see the bottom of the pond. But if you're throwing polarized light on top of the surface, all light is going in one direction, so you're able to see just the floor of the pond without any light being reflected. So this is exactly what happens on skin. So the top two pictures are an amelanocytic melanoma, and on the bottom we have a seborrheic keratosis. So the left side is polarized, the right side is non-polarized. So on the top, the white lines that are visible are very pathognomonic for melanomas and other skin cancers, and those are only visible if the light is polarized. If we looked at it under non-polarized light, we would say, this looks like a scar, there's no white lines to see. On the flip side, however, if you look at the seborrheic keratosis below, on the left side, the surface is not visible, right? So a lot of seborrheic keratosis are epithelial tumors. They're benign, but they're epithelial tumors, which means a lot of the structures are going to be on the surface. So if you're using non-polarized light is when you will actually appreciate, like the picture on the right lower part, you can see the crypts and the meliasis, which are pathognomonic for seborrheic keratosis. So that's your polarized and non-polarized dermoscopy. So then the next question is it worth it? Does dermoscopy work? In this meta-analysis from 2008, the authors concluded that dermoscopy is more accurate than naked eye examination for the diagnosis of cutaneous melanoma in suspicious skin lesions when performed in the right setting or in the clinical setting. And Marchetti and Margoob looked at, further sub-analyzed the data to show that the benefits apply not just to specialists, but also to generalists trained in dermoscopy. So it's worth our while to do so. In this prospective RCT, adding dermatoscopy resulted in 42% reduction in number of pigmented skin lesions excised for diagnosis. And in a retrospective study over 5 years among 2 dermatologists, the ratio of benign to malignant pigmented lesions that were excised significantly decreased from 18:1 to 4:1 with the addition of dermoscopy, so which means that fewer benign lesions were removed. There are certain lesions which you can't really, dermoscopy is not the end all, right? So there are some lesions which you look at and you think, it looks suspicious, but it's not really, so what do I do with this? And that's another benefit of doing dermoscopy is that you can follow these lesions along maybe every 6 months or every year, and this surveillance may help identify these so-called featureless melanomas, and then you can take them off if you feel that some of the features are malignant looking or dangerous looking. In this Cochrane review from 2018, the authors concluded that dermoscopy is a valuable tool to support visual inspection of suspicious lesions, especially in the hands of experienced users. Data to support its use in primary care are limited because there isn't much, but it may assist, dermoscopy may assist in triaging suspicious lesions for urgent referral when employed by suitably trained clinicians. So I want you to focus on that triaging. And they also concluded that formal algorithms may be of use for dermoscopy training purposes and for less expert observers. However, obviously we don't have much data for that. And the reason I focused on the triaging is a lot of physicians, again, will ask, why do I need to do? It's too much work to learn a completely new skill and so on. But I'm hoping that what you will take away from today is the knowledge that to triage pigmented lesions in primary care does not take a lot to learn to do that. And so I think all of us, all family physicians, should be able to use the dermatoscope to at least triage lesions. And obviously, if we have a formal algorithm to follow, it makes learning easier for a hands-on skill like dermoscopy. Margoob and Marchetti said that although dermoscopy is primarily used by dermatologists, any healthcare professional can learn dermoscopy. I have nurse practitioners, nurses, medical students using it in our clinics. They also, the literature also says that analysis by a trained clinician or an AI network can improve the diagnostic accuracy of melanoma. So that's another argument to say, why use dermoscopy when we have AI networks? I can just take a picture, plot it, and then it'll give me the answer. That is correct to a certain extent. We can't compare with AI and machines. However, my counter argument to that is that, you still have to take a good image to input the data, right, in order to get something back from it, which you may require dermatoscopic images to actually get benefit from AI. So if I'm saying that, and the literature is saying that anybody can learn dermoscopy, what's the data behind that? So in this one trial from Spain, 73 family physicians were trained with just 1 day of robust training, and then they were followed for about a year and a half, and the authors concluded that the use of dermoscopy improves the ability of primary care providers to triage lesions suggestive of skin cancer without increasing the number of unnecessary expert consultation. And these were followed up by histopathologic analysis of those lesions. A Dutch study concluded that the use of dermoscopy appeared to be cost-effective from a healthcare spending perspective. So even though we're investing a lot into these devices and learning, it's still worth it in the end. So in summary, dermoscopy increases diagnostic accuracy of melanomas. It likely increases diagnostic accuracy of melanomas in primary care, but we don't have enough data. Any clinician can learn dermoscopy. It is cost-effective from a healthcare spending perspective, and AI-based diagnostic applications will require, hopefully, dermoscopic and good quality pictures as data. So then the question is, are we ready to do it? Are we actually practicing dermoscopy? In this scoping review from UK, Australia, and Iran, the authors concluded, and I'll point your attention to the third row, which is all the countries, so USA, Netherlands, France, and Australia. And then this is where use of dermoscopy. And again, this is very rudimentary data, so we take it with a grain of salt, but it gives us some idea. So in the US, GPs are using dermoscopy between 6 and 20% and so on. But in Australia, 42.6 and 34%, so definitely exceeding any other jurisdiction in the world, at least from this study. And one of the things, one of the reasons for this, and I feel quite inspired by this, is the ratio of dermatologists to patients in Australia was far poorer than what we have in Canada. And they recognized this and collectively raised the competence in dermatology in procedural skills and dermoscopy for Canadian GPs and family physicians. So their College of Dermatology actually put out modules. They trained groups of people who went out and trained GPs. And so right now in Australia, they're very, very capable in primary practice to actually do flaps, grafts, diagnosis of lesions, and so on. So why cannot we be inspired by that and aspire to the same? So the outcomes or the more data from this scoping review show that the use of dermoscopy varies by jurisdiction. We don't have enough data. Obviously, it's a newer skill. Few family physicians use it, and those that use it tend to have a special focus or interest in dermatology. And those who do use it don't use it consistently, and majority of the time it's used for pigmented lesions. The family physicians who do use it are more confident in analyzing these pigmented lesions, and the barriers obviously are cost, both time and financial. And obviously the advantages are early diagnosis, reducing referrals, and reducing patient anxiety. And may I possibly suggest that it could probably help with burnout, because we're happiest as physicians, we're happiest when we're learning a new skill, and we enjoy the gratification if we can diagnose something for our patients and help them very timely. So the second thing that I pointed out in one of the slides was algorithms. So to learn a new skill, especially if it's a hands-on skill, you need to follow an algorithm. There are two main types of algorithms in dermoscopy. The first one is diagnostic algorithms. So that's where you have to know everything. And then there are triage algorithms. And we'll go through those, but pick one of the triage algorithm that we're sharing with you today. So the first one, the pattern recognition, there's consensus that the pattern analysis has the highest sensitivity, specificity, and diagnostic accuracy for detecting malignant melanomas. This algorithm requires extensive knowledge, obviously, and training to recognize the morphology of both normal and abnormal skin. And it's applicable to both pigmented lesions, non-pigmented lesions, parasites, hair, nail, etc., because you know the normal, and so you can pick up the abnormals. An example of that would be on the left. The two left-sided images are actually the image under dermoscopy of a scabies mite. So on the top, you just see a little delta wing-like structure. That's the thorax of the mite. And on the bottom one, you can see that clearly. And behind it is the track. And those little white dots that you can see, I'm not sure whether, yeah, it does show, those white dots are actually the eggs that the scabies mite has. And I've diagnosed this. I've seen this with my dermatoscope, which is very cool. On the right-hand side, we have a pigmented BCC on the right upper, and the lower one is a squamous cell carcinoma in situ, or Bowen's disease. And in the middle, so when you're talking about pattern recognition, you're looking at everything under the dermatoscope, right? So you're looking at, on the top middle, you can see in a basal cell carcinoma, you have three main things to look at. So arborizing or branching blood vessels, ulceration, and shiny white blotches or strands. So those are your main structures for BCC, and then there's some smaller structures that you can see that would support your diagnosis. So that's how that would work. And the second tip for today is Dermoscopedia. This is a fantastic website that has a very well-organized table of approach to dermoscopy, what do the structures look like, how do you diagnose them, and so on. So you're welcome to kind of peruse that as well at your leisure. So that's your diagnostic algorithm. And obviously, it'll take more time to learn all of those structures. But triage algorithms that came about within the last 10 to 20 years or so are quite numerous, but the one that we chose for us today is the three-point checklist. And the three-point checklist is valid and reproducible dermoscopic algorithm with high sensitivity, so 96.3% even after, in primary care physicians, even after 1 hour long training for that. For the diagnosis of melanoma in the hands of non-experts. Thus, it may be applied as a screening procedure for early detection of melanoma. And the authors basically came up with this algorithm, first of all, to encourage clinicians to start using dermoscopy. The goal is to identify lesions that need a biopsy or referral to a specialist, so truly triaging them. No patient should ever leave an office with an undiagnosed melanoma is what the authors say, or their motto for this book. And the presence of 2 out of the 3 criteria are highly suggestive of a suspicious lesion, and hence that should be excised. The sensitivity and specificity are comparable to other algorithms, and like I said, even after an hour training, novice dermoscopists were able to identify melanoma accurately 96.3% of the time. So what is the three-point checklist? So there's 3 parameters to look at if you're noticing, or if you're looking at a pigmented lesion with a dermatoscope. So asymmetry, atypical network, blue-white structures. And so if you have 0 or 1 out of 3, then you're not excising that lesion, but if you have 3 out of 3 or 2 out of 3, then the lesion is coming off. So delving a little bit into those 3 parameters, asymmetry is pretty self-explanatory. So you're looking at asymmetry in the shape of the lesion, but also in the color of the lesion. So again, if you divide it into 4, you can see if a lesion is symmetric or not. The second parameter is atypical network. Now, what is network? Normal pigment network is a grid-like reticular pattern. And histologically, the lines correspond to increased melanocytes along the elongated rete ridges in the dermis. And the holes that you see, the white areas, are actually the suprapapillary plates where there's less pigment. So just to show you, yeah, right there. So if you can see the pointer, this is where the dark line would be, corresponding to all this pigment right here, and the white holes would be these areas right here. And so an atypical network, so typical network would look like this. This is what the skin generally looks like, right, with the ridges and all of that, so these hexagonal patterns. However, if there's a melanoma or a destructive lesion, then obviously the architecture of the skin is modified. And so you will see these angulated lines, darker lines, they're usually gray in color, and it looks very irregular, and we have examples of that coming up shortly. So again, these are the holes, and this is kind of corresponding to the actual dark lines in there. And then there are blue-white veil or blue and white structures. So what is a blue-white veil? So in a melanoma, we normally see a lot of pigment. So a lot of melanin and melanocytes are going to be clustered together, right? That's why it's a melanoma. And so when you have a lot of pigment, that area is very, very dark. So it could appear really dark blue or black. Or if it has a lot of epithelial layers on top of each other, which is called orthokeratosis, obviously the yellowish tint of the top layers of the epidermis will change that dark pigment into a light bluish color. So that's what you're seeing in this picture right here. And then as the melanoma progresses, what's going to happen? The phagocytes will come in and they will take away the melanocytes, eat all of that up. The architecture is destroyed, and now what you're left with is just scar tissue, right? And that scar will start looking like these white areas, which are also called regression areas because all the structures are regressed. And then there's an in-between stage called peppering or granularity, which is where the phagocytes have taken away a lot of the pigment or the melanocytes, but some of the melanin is actually deposited in little areas, and so you see these little grayish dots, and so it's called peppering. They're usually very, very tiny, but they are indicative. They're just like dust particles, and so they're indicative of a melanoma. So again, to recap, the 3-point checklist is asymmetry, so asymmetry in shape or color, presence of atypical network, and blue-white structures. And to reiterate, 0 out of 3, 1 out of 3, don't excise that lesion, it's likely benign. 2 out of 3, 3 out of 3, excise the lesions. However, dermoscopy is not the end-all, right? So when you're examining patients, everything has to be in context. We know how common melanoma is, the 4th most common cancer in Canada. Lots of people are diagnosed, some die from it. But thankfully, because of early diagnosis, the incidence of mortality is decreasing. And of course, there's an enormous financial burden as well. And obviously, history and physical exam are absolutely key. So asking about family history, we ask about duration of onset, if the lesion has changed, and risk factors, so sun exposure, where you live and work, et cetera, but also palpation of the lesions. If I could ask you, what is the biggest differential diagnosis of pigmented lesions, the main one, what would you say? Seborrheic keratosis, right? So you have to touch the lesions, take a look at them, feel them, so that you know what they are. The other concept is kind of a pattern, right? So if you're looking at a patient and they have multiple moles on their body and you're looking at all of them through the dermatoscope, you're noticing certain patterns on them. And so not all of them can be a melanoma, but the one that stands out that is different is the one that you will really pay attention to. And so that pattern recognition is really key. And also epidemiology. So if we look at all the yellow and red areas in our country, we can see the areas that are hotspots for melanoma diagnosis. So in Ontario, the Maritimes, BC. But what I found really interesting was the distribution of melanomas on our bodies based on gender. So in most females, majority of the melanomas tend to be on the lower limbs. They tend to be smaller, so I've excised many melanomas from the thighs of women, and they tend to be micromelanomas, so they're smaller in size, very dark looking, innocent looking moles, but when you take a look at them, they're very dark, very pigmented, often come back as melanoma. Second most frequently would be on the arms, upper limbs, torso, and then the head and neck. And for males, it's almost the opposite. So their majority of melanomas on them are going to be on the torso, on the head and neck, followed by the upper limbs, and then the lower limbs. So again, if you have that information in your head, you can decide your index of suspicion for something being a melanoma. So let's apply this checklist quickly to a few lesions. So again, just to remind you, 3-point checklist is asymmetry, atypical network, and blue-white structures. So the first lesion here, is it asymmetric? Not really, right? It's fairly symmetrical. Does it have any atypical network? Not really. And you may be wondering about this kind of lighter area here. This is normal. It just means that you probably have a sweat gland here. And that's why there's a bit of a gap, right? So these are probably sweat glands right here. But otherwise, the network looks pretty normal and benign looking. And there's no blue-white veil. So this would score a 0 out of 3. No need to excise this lesion because it's a simple nevus. This one, on the other hand, it looks asymmetric, doesn't it? So it is asymmetric. Is there any atypical network? You could say yes, there is atypical network. Doesn't look like a normal skin network. Is there a blue-white veil? Not really. There are arborizing blood vessels, though. So just to kind of throw that in, but that's not part of the 3-point checklist. So this would be a 2 out of 3, which you would excise because this is a pigmented basal cell carcinoma. So another lesion, definitely asymmetric, right? You can see these angulating lines here. So the color is definitely asymmetric. Is there atypical network? Absolutely. You can see those angulated lines, the change in morphology of normal skin in pigmented skin. And you could argue there's a bit of that blue-white veil too, right? So right about here is where you see that, a little bit of that dark blue showing through. So this is a 3 out of 3. You would excise this because this is a malignant melanoma. What about this one? It's fairly symmetric looking. It doesn't have any atypical network because there is no network. There's a little bit of that blue-white veil you can see, but there's no need to excise this because it's 1 out of 3. It's a cherry angioma. So again, pigmented lesions can be multiple, where we're talking about the checkpoint, the 3 checkpoint list will apply to melanocytic lesions only. So again, same thing, there's asymmetry on this one, but the network looks pretty okay. And again, these areas are probably eccrine gland openings, and that's why you see those there. There's no blue-white wale, so 1 out of 3, no need to excise benign nevus. Let's take a look at this one. It does look fairly symmetric, right? It's dark, but it's relatively symmetric, or you could argue it may be asymmetric. It does have atypical network. It's really, really dark, and we look at these areas for atypia. It does have that blue-white wale, and in this case, there's no orthokeratosis, so you see the actual pigment. That's why it's not a hazy blue. It's actually a dark, dark black. So this is a 2 out of 3. We will excise this because it's a dysplastic, atypical, or Clark nevus. Here's another nevus. It looks fairly symmetrical. It does have the atypical network. There's no blue-white wale, so 1 out of 3. Do we excise or refer this? This one we probably will excise because it's a Spitz or Reed nevus, and sometimes it can mimic, these nevi can mimic dysplastic or atypical nevi. So anything where you see that starburst pattern or that kind of peripheral pattern, we always remove these lesions regardless, even though this one is a Spitz or a benign nevus. Another example, asymmetry, definitely atypical network. Yes, you can see down here, this kind of like the pseudopods or the arms that are coming out. That's where the melanoma is progressing. There is no blue-white wale, so 2 out of 3, we will still excise this. This is a melanoma in situ. That's why it probably doesn't have the blue-white wale or the peppering in there. Another lesion, definitely asymmetric, definitely atypical network. No blue-white wale, but this sign here usually is called the fried egg sign because you see the yolk and then you see kind of the side of it. It's 2 out of 3. We will excise this. This is a malignant melanoma in situ as well. Another interesting lesion. So it is fairly symmetric, no atypical network. It does have that white wale though. So then what is this? It's still 1 out of 3. You're not going to excise this. And again, that's where the clinical assessment is important because if you were to touch this lesion, it would be hard, it would be firm, and very well demarcated. This is a dermatofibroma. So dermatofibromas always have that white clear space in the middle. So we just wanted here to share with you that both Dr. Fong and myself weren't able to come up with any pictures of dark skin. And obviously this is on the net anywhere, and this has implications for practice because if we don't see that skin subtype, we can't diagnose it as well, right? As well for AI networks that are pulling information from the web and from different areas, if there's not enough dark skin lesions available, then obviously those AI networks and platforms are skewed as well. And so this is hot off the press from 2023, a scoping review looking at that there's limited depiction of darker skin tones and conditions that affect those with darker skin. So it was educational mobile applications aimed at students and professionals in derma. So basically educational applications don't have enough dark skin in them. And then last but not least, like I was saying, we look at patterns in the body, right? So these lesions almost look the same, but we're looking for beauty in nature and normalcy. So if it's symmetrical, if it looks okay, like it looks, basically looks beautiful, it's likely going to be benign. Anything that's asymmetric with harsh lines, color variations is likely going to be the beast or the abnormality. So even though they all look the same, this one stands out as having those irregular features. This one is with the typical cobblestone pattern that is pathognomonic for a congenital nevus. This one is benign. This one, like we said, dermatofibromas with that central clearing and that peripheral kind of pigment, again, looks very similar, but this one's a pigmented BCC. And you may ask, okay, once we've mastered the 3-point checklist, what's next? The 3-point checklist we chose because it gets you into the realm of dermoscopy and using it, getting comfortable with it. But we're all people that recognize patterns. So once you start using your dermatoscopes, you'll start recognizing pattern. And then the next step will be, okay, now I need to know what are the differential diagnoses for pigmented lesions, and I need to know the structures that make them what they are, and then you'll start recognizing those, and then that's how you expand your understanding and your knowledge of dermoscopy. So to start off with, use the 3-point checklist, and then you delve into differentials. And the one differential I'll quickly talk about is the seborrheic keratosis. We see this the most, so definitely touch lesions, because that's where you can see epidermal tumors will always be palpable, usually, I shouldn't say always, almost always palpable. And because these are superficial tumors, they are not pigmented per se, they're not melanocytic, they are pigmented, right? And so they can have milia-like cysts, comedole-like openings, fissures, fingerprint patterns, depending on their evolution. Early SKs look different from very well-established SKs. So they usually start off with like a fingerprint pattern, and if you see, this is not network like I told you. This is not network, this is just a pattern, because this is epidermal, this is superficial. Fat fingers, and then it looks like kind of moderate SKs will look like the brain in evolution, so they have gyri sulci, and when they're very mature, they can look quite scaly like that. So milia-like cysts, comedole-like openings, brain-like structures, sometimes just flat brown looking, but very well demarcated structures are often seborrheic keratosis. So as you start using your dermatoscopes for the 3-point checklist, you will notice then the next stage will be that you would want to know, okay, what do SKs look like? What are their morphological features? And that's when you go to your next workshop and you learn some of those features. So without further ado, we have a little quiz for you. If everybody can scan that QR code, we have a Pole EV quiz for you to take. And I'll hand the mic over to my colleague, Lin Feng.
Hi everyone, good morning. My name is Dr. Fong. So it's gonna help you guys go through some questions here. We always say practice makes perfect, and it's definitely true for dermoscopy and dermatology in general. So by now you should have a link to Pole EV, and we really hope that the technology is on our side today. You could use the QR code, or I believe there is a URL here. We're just going to get the poll start now, and just let us know if there's any issues at all. Most people good? Yeah? Perfect. Okay. So we're going to do about 14 questions. We're going to show you a picture of the lesions, and we're going to have this nice purple table on the side for you to refer. And just speaking from experience, you're going to be referring to this table a lot, and eventually it's just going to be almost like a reflex thing. You're going to remember the 3 points, and things get a lot more easier from there. But feel free to always refer to the purple table. And we're going to do the first 2 questions together, sort of guide you through. And I'm not going to release the answer because the poll kind of has to be completed entirely before we can go through all the questions together. But we're just going to sort of go through the motions and get you used to things, and eventually we're just going to get you to practice it again and again. Okay, we're going to start the timer here. Do I just click? Yeah? Okay. Oh, not really sure. Okay, all right. Okay, all right, we're seeing what we need to see. Okay, so this is the first question we have here. Again, hopefully you guys could see the purple table, might be a little bit too small, but just remember, number 1, asymmetry. Number 2, atypical network. Number 3, blue-white structure, so blue-white veil. And if it's 0 to 1 over 3, we usually don't excise it. 2 or 3 out of 3, then it's something that you might want to consider taking it out. So looking at this lesion here, all right, we have something that looks pretty over the place, So, would you say this is symmetrical or not symmetrical? We can look at the network. Do you see any network here? Are they typical? Do they look like they're pretty benign and you're happy to let them go, or they look like something that might cause some trouble? And do you see any blue-white sort of structure, blue-white discoloration? And you can give the 3 points, 3-point check, do the 3-point checklist, and come up with your score, and then you sort of decide whether you will excise or no need to excise. So each question you will have actually 2 answers to give, right? So the points and whether you're going to take it out or not, okay? So I'm pretty sure you can have time to go through the entire thing. So we're just going to go to the next question here. So again, this is a pigmented lesion. Things look a little bit chaotic, I would say. Would you say it's symmetrical? Do they look pretty even if you cut them into 4 quadrants? And to look for a network, there is some network here, and they look a little bit atypical for me, but that's definitely something to consider as well. And any blue-white kind of discoloration. So I would say those are the 3 questions that you'll always be asking your questions again and again and again. And just like Dr. John mentioned, 3-point checklist is like the most basic point system for you to get used to doing dermoscopy, but it is the most effective way and has probably the highest sensitivity. So the key-home message that we want to drive into your brains today is that the dermoscopy is used to let you decide if something can be left alone or monitor, or it's something that should be taken out for biopsy, which is really the diagnostic investigation that's going to tell you the pathology. So in this way, the 3-point checklist will always hopefully will always capture the all the lesions that might not be benign, and that's actually pretty much what we want to teach today. So from here on, we're just gonna let you go through all the questions on your poll, and you should have you should be able to access all of them in one shot. And we're just gonna give you about, I would say 5-6 minutes. We have about 10-11 minutes to go. So probably take about 6 minutes or so to go through them, and then we're gonna go through all the answers, see how we do, and do a little bit of teaching as we go through the questions.
I think we'll just give them 5 minutes. Yeah. It just moves on to the next one.
Yeah, I think the presenter version.
Yeah, that's probably why.
We do apologize, the timer's not working.
We'll just give 5 minutes.
We'll have about 5 minutes here. How's everyone doing? We're good to go ahead? Okay. All right, so let's just see if this works. Is it working? Oh, there we go. It doesn't show on my computer actually, but shows on the screen. All right. I'm just going to keep going back and forth here. So, first question, most of us have put 2 out of 3 for points, and most of us want to take it out. So that's actually great. So this is actually 2 out of 3, I agree. We have some asymmetry going on, pretty much going on everywhere. Could you guys see my cursor? Not really? Okay. So it's not symmetrical. The network, there is some network here on the right side, but not really typically what you would see in a benign lesion. You know, is there any blue-white structures? Not quite. There's a little bit of a clearing in the middle, but that's pretty much just like, I would say same color, the same shade of color as the skin around it. So you know it's not like a, what we call regression, where things actually sort of disappear, and you tend to see this in any non-benign lesion that's getting invasive. They start to sort of destroy the pigments, so to speak, and they actually get this like very stark white area. So one way I do it is I actually compare to the color of the skin around it, and that kind of tells me whether it's something to worry about. So this is actually a pigmented basal cell carcinoma, so good job on that. Moving on to the second one, so let's see here. Most of us have 3 out of 3, excellent, and I would say almost all of us wants to excise this, so that's great. I know it says 47%, but I think it kind of splits into half, so 47 is really almost 100%, so that's great. So this is actually a melanoma, and it's probably getting invasive in the middle there, which is why you see the white discoloration. That checks all our points. I just want to point, if you look on the side of the lesion, there's all this like what we call radial streaming. It's like sort of things coming out like a needle. That's actually a sign of bad stuff. So Spitz nevi, melanoma in situ, it signifies growth. So whenever you see those things, especially if it's not symmetrical, definitely something to watch out for. So for the third one, we have most of us 1 out of 3, and no need to excise. So that's actually accurate. We have here a seborrheic keratosis, and I would say this is a classic appearance. If you see an SK, you see all these fissures and ridges, are also called brain-like structure, cerebriform structure. Like, there's many words kind of talking about the same thing, and they just kind of reminds you of a brain. That's sort of what we see for a seborrheic keratosis. Sometimes you can see a little bit of a little meliasis in the middle. It kind of shines like brightly when you look at it through the dermatoscope, and that's another sign as well. But yeah, perfect. So moving on, we have what we call Starburst pattern, and we have 2 out of 3, and excise. That's great. So atypical network, I would say. Things are really looking really dark and almost like black, and you have all this like sort of what we call pseudopods. So all the little things on the side is pseudopods. How you tell the difference between that and the radial streaming that I showed you earlier. You see on the end there's a little bulb, like almost like a little round thing on top of a stalk, and the stalk is always connected to the main body. That's what we call pseudopods. That's actually a classic sign of Spitz nevus and in some melanomas as well. So it's something that we're going to have to take out for sure. All right, this is something that's even scarier. So most of us have 3 out of 3, perfect. So 3 out of 3 meets all the criteria. This is a melanoma, getting invasive on the right side actually. And this one is actually a, okay. So this one is actually a pigmented basal. I thought it was a pigmented basal cell, and it came out as melanoma. This is actually a case that I saw, and the pathology came out as melanoma in situ. And what I thought was what we call maple leaves patterns or things that we see in basal cell is actually atypical network. And right in the middle, that's kind of the regression I was talking about, where it just looks a lot wider than the skin around it, and that's a sign of melanoma as well. And I would say this one is 2 out of 3. Yeah, so pretty much atypical network, blue-white structure, maybe symmetrical, maybe not, but this one is definitely something to go. This is a really interesting case. It's a patient of mine. It came out looking really scary, and he was really concerned about it because he started bleeding a lot, and I think he was irritating it a lot as well. So, if you look at the 3 points, so this is a really good example of how 3-point checklist works, right? So would you say it's symmetrical? It could be. I would say like if you sort of split into 4, it looks pretty even. It definitely has an atypical network going on, and right in the middle, there's a lot of white, purplish thing going on. So this one I would say 2 out of 3, 3 out of 3. Either way, 2 or 3 means that it's something that you should excise anyway, so that's pretty much the point of the system. This actually is a traumatized benign nevus. So it's a mole that he's had for a long time, and he kept traumatizing it, and what you see in the middle is actually scarring. This is another good example of seborrheic keratosis. 2 out of 3, I do agree. Could argue to atypical network. Pretty symmetrical, I would say, or maybe not actually. There's a lot of darker discoloration at 11, 12 o'clock area, no blue-white structures, 2 out of 3. I took this out actually, so this is a case that I saw as well, and it came back as seborrheic keratosis. So another good example of how we called SK a great mimicker, because it can look like anything. It can look like a melanoma, it can look like a very classic SK that you're happy to leave it alone. Another example of SK actually, so I would say pretty spread out, some 1, some 2, and some say 0. Pretty symmetrical, maybe atypical network, maybe a bit of white discoloration. I would say it's probably more from discoloration from the methoscope pressing on the lesion. That's why it looks like it's almost a little bit whitish, but I think it's just from the plate, the glass plate pressing on it. So 0 or 1, something that we're happy to leave alone. This is actually SK. So this one, dark pigment, kind of reminds you of the case that we had just now, starburst pattern, things kind of sort of streaming out and spreading out from the periphery. It is very symmetrical though, but I would say the network is quite atypical. Blue-white structure, like, I know there's no blue, there's no white, but when you see a really dark, almost black pigment, it kind of reminds you of Spitz nevus, so we generally give 1 point to blue-white structure. So that gives us about 2 to 3. Definitely something that you want to take out, because if you think of Spitz nevus, it's always something that you want to rule out as melanoma. So we have this another case, pigmented lesion, a lot of asymmetry going on. I would say like definitely atypical network. If you look at the 7, 8 o'clock area, there's a lot of things sort of seeping out. That's the radial streaming that we're talking about. So this is actually a melanoma case, and definitely something that should be taken out. We're just going to go a bit faster here. This is another example of SK. I would say most of you has given it 1 or 2 points, so probably for asymmetry, atypical network, no blue-white discoloration, quite even on whether we're going to take it out or not. I would say like it's fair for this to be something for you to send to pathology and to make sure that it's not something funky like a growing melanoma, but it came back as a SK, so that's good news. This is actually a repeated question. Our apologies. And I think this is the second last we have. Again, I would say pretty symmetrical, but you could argue is asymmetrical. This is actually a really good example of globular pattern, which is what we call cobblestone pattern. It's a network, pigment network that you see in congenital nevi. And no blue-white structures, so most of you put 0 or 1 out of 3, something that you can leave alone or just monitor in about 3 to 6 months. That's great. Last case we have here, very thick sort of pigment network, so pretty atypical. It's a little bit of blue-white veil, right? It's almost like someone put a layer of like lace or something like that on the top and gives you that sort of opaque look. And pretty symmetrical, but either way it meets 2 points. So this is the beauty of the point system, right? If it's already meet 2 out of 3, you know it's coming out. It actually came back as a melanoma. So we just kind of briefed through all the quizzes, and those are pretty much just the starting of, if you were to go into dermoscopy, I would say that's actually a really good way to start and go into the world of dermoscopy. It's a huge wall, like we're still, both of us, we've been doing it for years and we're still learning on pretty much on a daily basis. What we have here is actually we came out with sort of like a course organization, association per se, that we were hoping to sort of gather more interest and perhaps come up with some workshops in the future for those of you who are interested. Because like we said, this is something that you're going to have to do a lot more learning and practice on a daily basis, go through a 3-point checklist, and perhaps advance to a more sophisticated, complicated checklist that's a little bit more specific. So that's something that we're hoping to achieve, and what we plan to do is that we're going to come up with more advanced workshops, and depending on the levels of training, we're going to be able to provide that at universities, institutions, and things like that. So we have on the left our Instagram QR code, so that it's easier for you guys to find us. And on the right is actually the website leading straight to our resources page, where we actually have a list of like organization or non-for-profit books and things like that we were hoping to share with you guys as well for more reading, and we have it on the website for you to browse through when you have time later, just for convenience. And I think we're pretty good here. Happy to take some questions. I do forgot to mention that we'll be happy to take any questions outside or as well. I brought a dermatoscope. Happy to show you guys how it works if anyone's interested.
I'm happy to take any questions.
What kind of swabs do you use to clean the dermoscope? Do they spoil the glass?
Yeah, that's a great question. And I'll let Dr. Fong answer herself. Every month or so, I will take apart the dermatoscope, all the parts that you can actually remove, and clean them with alcohol and the same that you would use for your glasses, and just wipe them, clean them, and put them back just to make sure there's no dust in there. But on a daily basis, if we're toggling between polarized and non-polarized, I will always use an alcohol swab. So I clean the patient's skin as well, and the plate that actually rests against the skin, and then I will use it that way. Do you use the same?
Yeah, I would say I would use the same thing. I mean, funny enough, I got my first dermatoscope, was ready to use it on a patient. I realized I don't actually know how to clean it. So I've tried a few things over the years. Ultrasound gel actually for cleaning, yes, it's alcohol. I've used the wipes. I learned it during our COVID period, so the wipes was everywhere, and then I was told after that would actually destroy the plate, so probably don't want to do that. Best thing is to just stick with alcohol swab. I always have like a bunch of alcohol swabs in my pocket. I use it as a contact medium, which is something that you'll learn about when we kind of go between polarized and non-polarized with dermatoscopes. You have to use kind of like ultrasound gel for ultrasound. You have to use that if you're using the contact method, which is for non-polarized. So I use the alcohol for cleaning in between patients. I use it as a medium for the plate to sort of stick on the lesion, and it cleans between patients. It cleans after, it doesn't destroy, it doesn't damage the device. So that would be what I go for.
Hi there. I first of all just wanted to thank you so much for this presentation. I went to one like this last year, and it got me into doing dermoscopy, and I now teach it to my residents at the University of Toronto as well. Woo! And I really encourage other faculty to really think about this. It's a really great skill to be able to learn. It's something that you can really learn by just investing the time in it, and it's a really, really great skill to have. And my question was just with one of the cases, the one that sort of was that atypical hypopigmented melanoma. I wonder when you see those types of lesions, it could be confused with a dermatofibroma as well, just because it kind of looked like that scarring. So I'm curious if you have any tips to make sure you don't kind of go down that diagnostic path.
Yeah, wonderful. So, I mean, obviously you want to use your polarized, non-polarized, right? First of all, to look for any signs that it could be cancer. So those shiny white lines are very pathognomonic. But again, when I talked about those equivocal lesions, which are just developing, they're not quite there yet because we're diagnosing them very early on, it can be very challenging. So even if you have a little bit of doubt or concern that this could be something else, the best thing would be to just do some surveillance. So, you know, the good thing in family medicine is that we have that longitudinal relationship with our patients. We can say, you know what, this is an interesting lesion. Let's bring you back again in about 3 months and we'll recheck it, or 1 month, whatever your index of suspicion is. That's what I would do, obviously going between polarized, non-polarized, and then just following for and doing surveillance and making sure you have a mechanism of keeping pictures, because that's how you will compare them, right? And usually because they're an aggressive tumor, they will develop and you'll start noticing signs.
Thank you.
So can we use that dimple sign for the dermatofibroma? Is
Oh,
it
yes,
all the time?
absolutely, absolutely.
I'll add something.
Yeah.
I would add to the question about the dimple sign. Every single dermatofibroma, for some reason that I cut out so far, doesn't have the dimple sign. Because I'm always looking for it, and none of them have dimples. I didn't cut them out, and they're dermatofibroma, although they clinically look like one. So I think what I learned afterwards is that the dimple sign, because it's scarring, right? Basically, that's what gives you the dimple. There's a scarring at the bottom. It's kind of tugging on the structures below. That doesn't really develop like until later after. It kind of needs time to develop. And what happens nowadays is, especially I find during COVID period, people are really a lot more attentive to things on their bodies and looking at lesions. And in some of them, like especially young people in their 20s, when they present to you with the dermatofibroma, they're actually on I would say earlier stage probably, so it doesn't have time to develop that yet. So dimple sign is definitely a really helpful feature, but I would say the lack of it doesn't completely exclude dermatofibroma. Again, you sort of have to combine the history, risk of the patient, clinical picture, the dermatoscopic look of it, and you always can follow things like 3 to 6 months later, because bad things always grow. Which is a really helpful rule actually. Not all the time, but most of the time they do. And that's the beauty of doing this in family medicine, because you actually have the privilege of doing that rather than having to find time to fit people in between consults. And the other, I think they took there we go. The other route I always go by, which kind of goes to the first question about how do you tell whether it's melanoma or dermatofibroma as well. If everything that you take out comes back as melanoma, you're probably missing out a lot. You should have a good balance of like things that come back as either atypical or benign, and then some malignancy. So that's something that sort of has assured me over the years that just because it comes back normal, it doesn't really mean that I've taken out unnecessarily. But that's usually how you screen for things.
And always pay attention to distribution, right? Where our dermatofibromas normally tend to be on the lower extremities and appendages, right? So if you notice where you're looking at, that should also point you into the right diagnosis direction.
Hi, thank you very much for a great talk. My question is, you've shown us, this 3-point checklist, but one of the questions, and you started answering, is about the surveillance and so on. So is there evidence about, the surveillance period according to the points that you have, 0 out of 3, 1 out of 3, so when to follow up? And then second question, so with all your knowledge and so on, what are your use with e-consult dermatologists, or when do you refer to a second line?
Sorry, say your second question again. What was the second question?
How do you, so since you, with the 3-point checklist, you either excise or non-excise, so when do you just refer to a dermatologist?
I see. That's so for the first part of the question, looking at surveillance. So there's 2 aspects to surveillance, right? One is surveillance of patients who have or who are at a higher risk of melanoma or cancers, right? So then we'd follow the Cancer Care Ontario's guidelines for skin surveillance. And as far as if you're talking about equivocal lesions that you're not really sure, you're sitting at the cusp, then you decide kind of how frequently follow up. So if I'm worried about a melanoma, or if my index of suspicion is high, I may get them back in a couple of months or 3 months at the most. And so that would be kind of my follow-up for equivocal lesions. And in terms of, do you do anything differently, Dr. Fong, for those?
I would say like pretty much similar. I guess to your questions about when do I decide to e-consult versus follow myself or send to dermatology, I think we're in a pretty unique position, which sort of, what makes us have the advantages sometimes is you have sort of the background for family medicine and also the family physician of the patient, if it's your own patient, and you have like extra knowledge about dermatology. I think what I usually do is that if it's someone that I know has high risk of cancers, and when I look at the lesion, I'm not really sure if it is not enough for me to proceed with procedures. Like either they're frail or they have blood thinners, any reason that kind of makes it a higher risk of a procedure. And there's benefit of not cutting it out, but at the same time, I kind of 100% sure that it's benign. I could follow in 3 to 6 months. It looks even weirder. And you're sort of stuck in between. I would say that's a really good example of a case where like this patient should really go to dermatology. Anything that you're not sure of, like you're gonna have to talk a lot to your local dermatologist and dermatopathologist. And that's something that sort of, the network that you acquire in wherever you work.
And also depends
yeah.
on the province that you're working.
Yeah.
In Ontario, in London, Ontario specifically, dermatologists maybe, but the wait time is quite long. But if I'm sending somebody to a plastic surgeon or our skin cancer clinic, they will not entertain any referrals without a tissue biopsy or a pathology report. So per force, even if we have, if our index is for the 2 out of 3 and the 3 out of 3 lesions, I will probably biopsy that. And if it's a larger lesion that requires grafting or flap work, et cetera, cosmetically, then I will definitely do the biopsy and then refer them to plastic surgery. But I'm not sure in your jurisdictions, if plastic surgeons accept referrals without biopsy, then obviously you have that option as well.
Okay, thank you.
Well, thank you for the presentation. I have a question here. If I want to order a dermatoscope, where can I buy it from, or where can I order it from?
Sure. So the 2 main companies are the Hein, that's the one that I use, and the Dermlite. And both these companies do sell their dermatoscopes online, and they'll ship them out to you. Now, Dermlite has a perennial discount rate for all students of dermoscopy. And so, on our website, the QR code that we showed, there's a link to that and the code that you have to use. Again, we're not benefiting from it. This is a perennial code that's available for anybody, anywhere. You can use it throughout the year to purchase a dermatoscope. So it's 35% off. But if you talk to the Hein people as well, you'll have to probably email them, and they may be able to offer you some discount as well. So basically online right now, or if you're lucky to get to a dermatology conference like the PCDSP that I told you about, the link of that is on our website, again, for information exchange. And also there's different dermoscopy and dermatology conferences. They usually have vendors where you can pick them up at very good discounts.
I have another question too. Now, I appreciate the 3 points checkup, but we used to, say if the lesion is more than 6 millimeters, or if it changes in size, or changes in, and if it get raised. You didn't mention anything about that. It's just the...
Excellent question. And I think the slide that had the history, physical exam aspect of it, that's exactly what I meant, that you would have to put your dermoscopic finding in context with the history and physical exam. And I'll give you a really good example of that. One of the most frequent consults that we do are for congenital benign nevi. These nevi obviously are present from birth or infancy, and they tend to grow with our bodies. And oftentimes we see an unprecedented growth in them around the time of puberty. So they do tend to become more rounded, they can be larger, and sometimes they can be bigger than a few. Congenital nevi can be quite large, and if they're above 1.5 centimeters, there's more likelihood of cancer in them. So those are the ones that you'd be interested in, the larger ones, and you can use the dermatoscope to look at different areas within that. But again, pregnancy too. So a lot of the times congenital nevi will grow with pregnancy. So as you start using the dermatoscope and you start noticing these patterns, you're already way ahead, right? You're already now thinking, okay, I'm seeing this pattern, what is this? And so then you'll start exploring that, and then you'll see kind of the cobblestone pattern, with the congenital nevi, the way they grow on history with your body and so on, and so that's how you'd look at it. But obviously the ABCD rule applies to any pigmented or melanocytic lesion, and we continue to educate our patients and ourselves about that. Anything that's changing, it's always a good idea to have your doctor take a look at them.
Thanks.
I forgot to mention, we're going to upload the code for the discount right after this. So if you don't see it right now, that's probably why. Anyway, thank you so much, everyone, and hopefully we see some faces again in the future.
And we're around here if anybody has any questions. Thank you. And thank you to Joe and his team.